for this patient.
Good afternoon, everyone. My name is Jonas. I am one of the faculty cytopathologists at Weill Cornell Medicine in New York. I'm also the vice chairman of the ASC eJournal committee. I'm delighted to welcome you to the May edition of the eJournal from the ASC. I'm joined today by our chairman, Dr. Lee at Hopkins, and two of her former trainees, Dr. Hansen Lam and Dr. Carla Saoud, who as fellows were the first and second author of today's Journal Club paper entitled Degenerative Atypia in Benign Thyroid Nodules, a Potential Diagnostic Pitfall on Fine Needle Aspiration. So like I said, I'm at Weill Cornell, but Dr. Lam and Dr. Saoud have actually moved on from Hopkins, and they are now both fellows across the street from us here at Cornell at Memorial Sloan Cancer and Cancer Center. Dr. Lam as a general oncologic surgical pathology fellow, and Dr. Saoud as their bone and soft tissue pathology fellow. Welcome to you both. Objectives for today's session are fourfold. First, to identify potential sources of diagnostic error in FNA cytopathology of histologically confirmed benign thyroid lesions. Second, to highlight the clinical consequences of overcalling degenerative atypia as malignant or potentially suspicious for malignancy. To refine criteria for thyroid lesions harboring degenerative atypia using the Bethesda system, and ultimately to prevent false positive thyroid FNA diagnoses. So the story for the research that Dr. Lam and Dr. Saoud did along with their colleagues starts, as all great research does, with prior research. So it was built on a review of several larger studies that weren't necessarily focused on histologically benign nodules, but included a number of histologically benign thyroid nodules that had preceding FNA cytology. And it looked at the rates of false positive diagnoses in these studies. They ranged from 0.2% to 7.1%, and in aggregate, it was 2.3% among these larger studies. Now, it's important to point out that in no way is this 2.3% number an accurate representation of the abilities of the Bethesda system to diagnose thyroid nodules, as many lesions that are diagnosed as either benign or atypical by FNA will not have histologic follow-up. And those, many of them can assume to be benign. So that number is most likely lower than 2.3%, but we want the number to be as low as we possibly can because there are real consequences for false positive FNA diagnoses. Now, among these studies, one of them was actually written by a subset of the authors of the current study, and that was the one by Olson et al. And that was published in 2011 in Acta Cytologica. And they weren't, again, specifically looking at false positives. They were looking at the spectrum of risk malignancy and subcategories of atypia of undetermined significance. And because it was published in 2011, they were using the first edition of the Bethesda system, but the principles still apply. So what did they do specifically in that previous study? So they looked at the risk of malignancy as determined by cytologic histologic correlation, and they had a great number of FNAs in their study, nearly 4,000 total thyroid FNAs in their study, of which nearly 400 were called AUS or Bethesda category 3. Now that 9.8% number as their rate of AUS at the time would have been a little high. Remember, the first edition of the Bethesda system used 7% as a cutoff for the rate at which laboratories should be calling AUS. The number was eventually revised to 10% for the second and now the third edition of the Bethesda system. Also, 32% of those nodules were malignant or NIFTP based on 143 resections. And again, that's a higher rate of malignancy than you'd like to see in AUS, but again, many of these do not undergo resection, and those can be assumed to be benign. So that 32% number really makes sense. Now, among those 433 histologically benign nodules in this previous study, 15 or 3.5% were diagnosed as either suspicious for malignancy or positive for malignancy on FNA. And the question is, what makes these different? What types of atypia were causing the pathologists in these cases to overcall them, quote unquote, overcall them as either suspicious or positive? So luckily, the Bethesda system for reporting thyroid cytopathology does subdivide different types of atypia. The third edition recognizes two types of atypia, either nuclear atypia or other, but those two categorizations roll in categorizations from previous versions. So in the second edition, focal nuclear atypia, extensive but mild nuclear atypia, atypical cyst lining cells, and histiocytoid atypia, as well as a combination of nuclear and architectural atypia would fall under the current nuclear atypia rubric, whereas architectural atypia, oncocytic, or what used to be called Hürthle cell atypia, atypia not otherwise specified, and lymphoid atypia now fall in the broad category of other types of atypia. But of course, there are other types of atypia not in those lists that have been described in previous literature. So these include previously described and common sources of atypia, such as Graves, atypia associated with Graves' disease or toxic goiter or lymphocytic thyroiditis. In my presentation here, I've only included some pictures of lymphocytic thyroiditis. I think we're all familiar with what Graves looks like. And in lymphocytic thyroiditis, one might find nuclear grooves, powdery chromatin, or even some chromatin clearing with variable oncocytic change in a background, usually of a significant number of lymphocytes. There are also some previously described and uncommon sources of atypia. These include dyshormogenetic goiter, Graves' disease after radioactive iodine, and external beam radiotherapy. Again, I've only included pictures of goiter and radioactive iodine here, but the same principles apply for external beam radiotherapy. One might see microfollicles, anisonucleosis, hyperchromatic nuclei with bizarre forms, and focally conspicuous nucleoli, as well as specifically in Graves' disease, some flame cells. But Dr. Lamb and Dr. Saoud decided to focus on a different type of atypia, and they termed it degenerative atypia. When I was a resident and fellow, I learned it as endocrine type atypia. And this is a type of atypia that's been defined mostly in the histologic literature. In the cytologic literature, it's not particularly well defined or documented. I learned it in residency as sudden or random nuclear hyperchromasia and enlargement, or anisonucleosis, although it can also be associated with poorly preserved or suboptimal specimens that have been described in a couple of papers, mostly from the BI group in Boston. What's important to know is that this is not strictly nuclear, architectural, oncocytic, or other types of atypia currently included in the Bethesda system. So my question for you, Dr. Lamb and Dr. Saoud, is why did you decide to focus on this type of atypia?
So so as we all know, like from histology, there are these thyroid that usually show like this degenerative and endocrine type atypia that you were talking about. So we wanted like first to see how these were called on cytology, and mostly to raise awareness among cytopathologists that this can be seen in cytology specimen, and not to overcall them like suspicious for malignancy or malignancy.
Yeah, that's great, thank you. I mean, obviously a very, very important topic. And Dr. Lamb, how did you define degenerative atypia for this study?
So yeah, we defined degenerative atypia for this study as scattered cells with abundant cytoplasm, but marked nuclear pleomorphism in the form of bizarre hyperchromatic nuclei, and kind of a like you mentioned earlier, like a lack of other types of atypia that may be commonly associated with PTC and etc. So that's how we define it for this study.
That's great, thank you. I mean, pleomorphism particularly can be really scary. After all, we don't get as many of the architectural clues that our histopathology colleagues do, and so we really tend to focus on nuclei, and when they when they lie to us, it can be quite scary. So the study aims in the study were to identify nodules with histologically confirmed degenerative atypia, to analyze cytomorphologic features of corresponding FNA samples, and to identify potential sources of diagnostic error, and specifically false positives, not necessarily false negatives. And they defined false positives as either suspicious for malignancy, Bethesda category 5, or positive for malignant cells or malignant, Bethesda category 6. One thing that I really liked about this study is that it was a multi-institutional study with retrospective correlation. For those of the trainees on the line, I can only tell you how, one, difficult and two, rewarding it is to do studies across institutions. And I think it's terrific that Dr. Lamb and Dr. Saoud were able to work with their colleagues at Penn and Harvard on this study. In the study, they describe it as a cytologic histologic correlation, although if you really read into the fine print, this is kind of, they did two different correlations, a clinicopathologic correlation and a cytologic histologic correlation. In terms of how they identified their cases, this was a pretty straightforward keyword query in their laboratory information system. They were looking at histologic specimens with the word thyroid and either degenerative atypia or degenerative change. And then very simply, corresponding FNAs were collected and reviewed. Anytime you're talking about cytomorphology or retrospective review of cytologic specimens, you always need to talk about specimen preparation. And so it's important to note that for those specimens that were at Hopkins, they had paired DiffQuick and PAP direct smear preparations, and the DiffQuicks were used for rapid on-site evaluation. Cytospins and or liquid-based cytology were available in select cases only. However, at the other institutions, they used primarily liquid-based cytology, and direct smears were available in select cases only. It's also important to note that all discrepant resection specimens were reviewed by a subspecialty head and neck pathologist. So the first thing they looked at were the clinicopathologic characteristics of their study. And there's a lot of numbers in this chart. I won't take you through all of them, but one thing that I really want to point out is just the great number of specimens that they looked at. So there were over 4,000 total patients with resected benign thyroid nodules. And the number of patients with resected nodules showing degenerative atypia was actually quite high, nearly 350, which would be about 8%. Of those, the number of patients with preceding FNA cytopathology was also quite high at 123. So they had 123 in their study. They had a few QA metrics that they looked at, and one of these was the non-diagnostic rate. So there were 4 non-diagnostic specimens, 3.3%. And this is actually quite low, both in laboratories that use direct smears and those that use liquid-based cytology only. So there, it does appear that there is something about these specimens that make them diagnostic at the very least. It's also important to look at the AUS rate. So in this case, it was 30.1%. Now remember that the Bethesda system recommends keeping your laboratory's AUS rate below 10%. Remember, but all of these had some sort of literal atypia, degenerative atypia. So an AUS rate in this population of 30% is somewhat expected. It's also important to note that the malignancy rate in this case was low at 1.6%. So there was a paper in cancer cytopathology, again out of the BI group at Harvard, back I think in about 2011, maybe 2012, that recommended using the AUS to malignant ratio as a QA metric, and they recommended that laboratories keep their AUS to malignant ratio below 3. Well, in this case, it's much higher, suggesting that they are not overall calling a ton of their AUS of these atypical specimens as malignant. So that is a relief. It's also important to note that they did find one false negative in their case. There was one case diagnosed as Bethesda category 2 or benign in which they did find atypical cyst lining cells, so a false negative rate of 1.6%. But what they were really looking at was the false positives, and they identified 5 nodules for which the FNA was quote unquote overcalled or false positive, 3 called suspicious, 2 called malignant. So what do we know about these overcalled nodules? Well, 3 of the patients had a history of hypothyroidism and were on hormone therapy. Of those 3, 2 of them had a remote history of external beam radiotherapy for classical Hodgkin's disease, and the one who had not had external beam radiotherapy had a history of lymphocytic thyroiditis. Perthal cells, or what are now called oncocytes, were present in 4 of the 5 specimens. Cytologic or nuclear atypia was present in all 5, and architectural atypia was present in none of the 5. So what we're really talking about here is nuclear features, although, as you will see, Dr. Lamb and Dr. Saoud did identify some other features other than nuclear atypia in these specimens. There were also real clinical consequences to these overcalls. So all 5 of these patients underwent a total thyroidectomy, potentially unnecessarily, and 2 of them, in fact, underwent prophylactic central neck dissection. So what about their Bethesda classification, the cytologic characteristics, and the management? Well, another thing I really liked about this study is that they really dug into the cytologic features very specifically for a great number of their cases. I won't take you through all these numbers, but just to point out just how rigorous this study was. I also want to point out that the overall mean age for the specimens they included, or for the patients with the specimens they included, was 53 years with a range of 18 to 85, which is correlates with a lot of other studies that you see in the literature across different thyroid studies. So in terms of age, there's not much difference between their population and the general population. And again, 71% were female, which again correlates with what one might see in studies of other types of atypia or thyroid FNA in general. What's also interesting is that regardless of whether these were called benign, AUS, or follicular neoplasm, in other words, categories 2, 3, 4, but for the Bethesda system, it really didn't make a difference on how these patients were managed. A slight majority in each category underwent hemithyroidectomy, with a slight minority undergoing total thyroidectomy. However, those that were overcalled, every single one of them underwent total thyroidectomy, and again, the 2 that were called malignant actually underwent prophylactic central neck dissection. So the real breakpoint here is between categories 2, 3, and 4, and then categories 4 and 5, which are the ones that Dr. Lamb and Dr. Saoud focused on. So why don't we look at these cases more individually? So thyroid FNA number 1, which was quote unquote overcalled as suspicious for malignancy. It was called category 5 above the line, and below the line, it was called quote unquote suspicious for carcinoma without specifying a type. You can't see it in these pictures, but the smears were hypocellular and devoid of colloid. And cytologically, this really looks quite ugly. There's, as Dr. Lamb pointed out, real pleomorphism. And these are kind of syncytial clusters, indistinct cell borders, even some hint of spindling here. And even though this is a diff-quick, you can still see that there's a prominent centrally placed nucleolus in one of these cells. However, histologically, despite this atypia, this degenerative atypia, this was a follicular adenoma. I don't have pictures of cases number 2 and 3, but both of these were also called suspicious for malignancy. One was called below the line suspicious for papillary carcinoma, and the other one was called concern for follicular-derived carcinoma. The one called suspicious for papillary carcinoma had scattered small sheets of cells with abundant finely vacuolated cytoplasm and enlarged round or ovoid nuclei with irregular membranes. And on resection, it turned out to be just an adenomatoid nodule. The one called concern for follicular-derived carcinoma had scattered large pleomorphic cells with abundant cytoplasm and markedly enlarged, irregular, and hyperchromatic nuclei. And on resection, it was an adenomatoid nodule with focal oncocytic change. Here are some pictures of thyroid FNA number 4, which was called positive for malignant cells. This one looks a little bit different. Here we have flat sheets with prominent cell borders. Again, elongated cells, and here the cytoplasm is a little bit more dense, maybe microvaculated, but a little more dense than the other ones we looked at. But there's real irregularity to the nuclear contours here, and even in one cell, there's a true pseudo-inclusion. This one was actually called poorly differentiated carcinoma because it's tough to tell on these images exactly what type of carcinoma it is, but it does have a vaguely insular architecture. You can't see from these pictures, but the smears were cellular with scant colloid. But on resection, this was a follicular adenoma in a background of lymphocytic thyroiditis. Finally, thyroid FNA number 5, which was also called malignant or positive for malignant cells. This one was actually called anaplastic thyroid carcinoma. And I think you can see from these images why it was called as such. There is frank anaplasia in these cells, as well as some spindle cells and very prominent centrally placed nucleoli. What you can't see in these images is that the smears were cellular, again with scant colloid, but on resection, this was an oncocytic adenoma, and it was only 1.7 centimeters in size in a background of dense lymphocytic thyroiditis. And I will just point out here that clinical correlation can be difficult. It can be, difficult to wrench that clinical information from our clinical colleagues, but a 1.7 centimeter anaplastic carcinoma on FNA is quite unusual. But Dr. Lamb, Dr. Saoud, and their colleagues did not stop there. They actually added an additional notable case, which wasn't strictly "quote unquote" overcalled. It was called suspicious for molecular neoplasm, or what would now be in the 3rd edition of the Bethesda system, just plain follicular neoplasm. But below the line, the pathologist in this case did note pronounced nuclear atypia, raising the possibility of a poorly differentiated carcinoma. This was a liquid-based cytoprep only, and so that's what we're looking at here in this image. What you can't see is that it was hypocellular with scant colloid, but there is, again, real nuclear pleomorphism and prominent nucleoli in this image. However, on resection, this too was a follicular adenoma. So how do we put this all together? What are the common features, the common cytologic and I guess histologic features as well that we can glean from a real in-depth granular look into these overcalled or false positive cases? Well, cytologically, what Dr. Lamb, Dr. Saoud, and their colleagues found was syncytial sheets or loose clusters that were best visualized on DiffQuick when the DiffQuick was available. The cytoplasm in these cases was granular or finely vacuolated, and the nuclei were hyperchromatic with fine, even chromatin and conspicuous and centrally located nucleoli. Now, histologically, one thing that I found interesting that they described in their paper is that the atypical cells, the cells that demonstrated this degenerative atypia, were seen both within the nodules and the internodular areas, suggesting that this kind of atypia is not necessarily neoplasia related, that it's something about the patient or the patient's thyroid, or something about a medical condition or a drug that they're taking that's affecting the whole thyroid and not necessarily just the radiologically apparent nodule. There was also a background of nodular disease with varying degrees of fibrosis. There was oncocytic change in 3 of the 5 resection specimens and lymphocytic thyroiditis in 2 of the 5 specimens. So in terms of discussion, they noticed that degenerative atypia does not contribute to a large proportion of false positive thyroid FNA diagnoses, which is good considering that degenerative atypia is actually seen again, an 8%, quite a large number of these specimens. But despite the low number, the consequences were quite high. So in most cases where degenerative atypia is quote unquote overcalled, serious diagnoses such as anaplastic thyroid carcinoma may result in aggressive management. And in these cases, it would be prudent to rule out radioactive iodine treatment, particularly in the setting of Graves' disease, external beam radiotherapy, dyshormogenetic goiter, and radiologic features of aggressiveness, including size. There was a limitation to the study, specifically as reporting practices differ between diagnosticians and institutions. Degenerative atypia may not be documented in all surgical pathology reports. Therefore, it is difficult to accurately assess the true incidence of degenerative atypia among histologically benign thyroid nodules. So they may have missed a couple of cases, but I think the conclusions that they made are still valid, especially since they really looked in depth at these cases. So with all that in mind, I did pull a case from my own files. It actually wasn't my case, but I think it's illustrative of a slightly tangential point, but I think it could be helpful. So why don't we take a look at this case study with history and imaging. So the following thyroid FNA comes from a 67-year-old man with a history of type 2 diabetes, heart failure, and end-stage renal disease on hemodialysis. And he had an incidentally identified thyroid, or several incidentally identified thyroid nodules on a chest CT, which was done in the setting of volume overload. After the chest CT, he underwent a dedicated thyroid ultrasound, which showed multiple bilateral nodules. The most suspicious nodule was in the right lower pole. It was 1.9 centimeters, solid, hypoechoic, not taller than wide, and it had lobulated margins, but no echogenic foci. There was also an isolated enlarged lymph node in the contralateral neck that actually demonstrated a loss of its fatty hilum. So on DiffQuick, what you can see is that this was a relatively hypercellular specimen, and it was devoid of colloid, almost entirely devoid of colloid. As you can see, these are syncytial clusters of cells with some nuclear overlap, vague microfollicular architecture, and a smattering of lymphocytes as well in the background. On PAP, the chromatin was slightly more open than we generally see in strictly benign thyroid nodules, but for the most part, the nuclei were round, dark, and granular, again with some hint of a microfollicular architecture. Similar features were seen on a liquid-based prep, very little colloid. There was actually some blood and fibrin in the background, but again, small, round, dark, granular nuclei in a vaguely microfollicular pattern. So I hope the poll works. We have, if we can put the poll, I am curious as to what the membership of the ASC would call this. I can't see from here. Is the poll up?
The poll is up, and we are receiving responses. I'll give it another few seconds and then I'll close it. Okay, your results are up.
Okay, it is a little bit hard for me to see, but it looks like a slim majority would call benign and a slim minority would call AUS. Nobody in the other categories. That's interesting. When I see a lack of colloid, I start to get a little bit nervous and I tend not to call these benign. Again, this wasn't my case, but this was actually put in category 4, suspicious for follicular neoplasm, which would now be follicular neoplasm. With the microfollicular architecture, the hypercellularity, the lack of colloid, I actually think it does fit strict Bethesda criteria for category 4, but that's a big call. The usual management here is potentially diagnostic lobectomy. So I think it's perfectly reasonable to back off a little. At our institution, all FNAs in categories 3 or 4 are sent for molecular testing. The molecular test that we send for is determined per clinician preference. Again, myself, Dr. Lamb, and Dr. Saoud have no financial interest in any of these tests, but this one was sent for the AFIRMA test, the genomic sequencing classifier, and in this case, parathyroid signature was detected. And the reason I brought this case is that even though every case in Dr. Lamb and Dr. Saoud's study turned out to be thyroid, you should be aware that degenerative or endocrine type atypia can exist in other organs. You can see it in parathyroid adenomas, which are sometimes sampled during a thyroid FNA, paragangliomas, or even extrathyroidal malignancies like a metastatic renal cell carcinoma. So think about something else to think about. Is this degenerative atypia leading me to overcall a nodule, or is this thyroid at all? So conclusions. False positive diagnoses of degenerative atypia may expose patients to undue surgical procedures and risks. Cytomorphologic characteristics of degenerative atypia include the following. Perthel cells, or what are now called oncocytes, with nuclear atypia, characterized by hyperchromatic nuclei with fine, even chromatin with conspicuous, centrally placed nucleoli, and syncytial sheets with lack of architectural atypia. Now, per Bethesda category, the Bethesda system version 2, the authors suggested to consider assigning these samples with degenerative atypia to the AUS-NOS subcategory. Well, my question to you, Dr. Lamb and Dr. Saoud, is to which subcategory should nodules with degenerative atypia be assigned per the current version 3 of the Bethesda system?
Yeah, we were thinking perhaps still NOS, just because there was specific mention in the Bethesda system to kind of similar type atypia in a specific reference to Graves' disease post radioiodine therapy, and I guess it seems that can produce very similar cytologic findings.
Yeah, I think that's a spot-on assessment, doctor, and so that would fall into the atypia other category, not nuclear atypia, but other. And other future directions, obviously, can we refine Bethesda diagnostic criteria? Other future directions is, are there any diagnostic modalities other than good old-fashioned morphology that can help prevent false positive diagnoses? The two that I came up with in my head were digital pathology, computational pathology, artificial intelligence, or perhaps maybe we should be sending everything that we see that has this kind of degenerative atypia for molecular testing. I don't have the answer, and I was hoping, Dr. Saoud, that you could speculate on whether there are any diagnostic modalities that can help prevent false positive diagnoses.
Yeah, sure. I mean, sending for molecular testing, I think, would be good, because those usually will not show, like, at least the PTC. They might show like the RAS, which will be seen like in a follicular adenoma. But yeah, at least they will not show the PTC related alterations.
I would never deprive just that.
Yeah, I think that's a great recommendation. Obviously, molecular testing is subject to the whims of things beyond our control, such as insurance companies. Will they pay for it? But this kind of research is really a great start in showing what the benefits and the pitfalls are of a good old-fashioned cytomorphology, and maybe molecular tests, as you mentioned, RAS mutations, RAS-like mutations, maybe even P53 or TERT promoter, can help us prevent false positive diagnoses. Obviously, there may be some people watching this that are more interested in kind of the wet lab bench research. And for those, a future direction might be, can we define the timelines and mechanisms by which this kind of degenerative atypia develops in different clinical contexts? And that would help us kind of glean the meaning of this degenerative atypia. But again, that is all for the future. That's all I have. I thank you for your time and attention, and I'm happy to take any questions. And since Dr. Lamb, Dr. Saoud, and Dr. Lee are here as well, maybe they can either ask or answer questions as well.
If you have questions, you can enter them in the question areas. I do see one question that came in, and it says, couldn't IHC stain be helpful to some extent? HBME1 in case of suspicious PTC or thyroid globulin in case of suspicious anaplastic carcinoma?
I think that's a great question. I will say that it is uncommon that we are able to or even attempt to get cell blocks on our cases. On top of that, the great number of our thyroid FNAs are collected in Cytolite, and CAP guidelines, again, it's not a CAP requirement, but CAP guidelines are to exercise extreme caution when doing IHC on Cytolite fixed cell blocks. That being said, I sure have done it. And one HBME1, an old stain, along with I think it's galectin 3 and CK19. These are imperfect stains. One stain that I like to use, especially in patients with a known history of malignancy somewhere else in the thyroid, is a BRAF V600E immunostain. It's highly specific, even though it's not highly sensitive. And you should remember that the most common driver alteration in both poorly differentiated and anaplastic thyroid carcinoma is still BRAF V600E, even though they can arise out of RAS mutated nodules. That being said, I am curious what you guys did at Hopkins in your fellowship and what you, Dr. Lee, currently do at Hopkins in terms of cell block construction and IHC on thyroid FNAs.
Yeah,
We sometimes
oh yeah, sorry, go ahead, Carla.
we sometimes use the BRAF IHC, especially on like the anaplastic ones.
Yeah, but I mean, today's presentation really practical and educational, and especially for those 5 false positive cases. And in Hopkins, usually we don't do cell block preparation. Occasionally, like for the Jonas, for your case, like if we're suspicious for parathyroid, usually we'll make cell block. So I mean, on-site evaluation will send for parathyroid hormone, and also we'll make cell block in case if we need to do immunostudy. But in general, we don't make cell block. But I mean, from those 5 false positive cases, to my impression, the cellularity looks like relatively low, but still very difficult cases, especially in case number 4. There is wild form pseudo intranuclear inclusion. That's really difficult. And those cells looks pretty morphic. The nuclei, the size, the variation. So I think it's very difficult cases. And I also agree with you guys. Maybe molecular study is another alternative solution for those, looks atypical cells cases we send for molecular. So maybe we'll have a better answer, and also correlate with radiographic findings. So maybe a better solution. But overall, very difficult cases and a very good educational material. Thank you, guys.
Thank you, Dr. Lee. I think that's important for everyone to keep in mind. There is another question that has been sent to me privately in a chat, and I can't tell who it came from. It says, if a case with similar morphology to degenerative atypia did turn out to be carcinoma in the end, what type would it most likely be, D. diff or anaplastic? Remember, these are quote unquote poorly differentiated rather than de-differentiated. But I think that's just, this was a question that was copied from the questions to the chat. I see. Thank you, Joanne. So poorly differentiated anaplastic, and now there's a whole new category. Since I was a trainee, there is differentiated high grade. So add on top of that there are variants of which are still differentiated. So differentiated with variants, differentiated high grade, poorly differentiated, and anaplastic. And I don't have a good answer. Dr. Lamb, Dr. Saoud, if one of these did turn out to be carcinoma in the end, what type of carcinoma do you suspect that it would be? I mean, some of these cases really looked like they had frank anaplasia, but atypical cyst lining cells can look frankly anaplastic. I'm wondering what you guys think.
Yeah, it seemed that like when we looked back at those cases that were overcalled, the kind of hint in the bottom line was either towards like anaplastic or maybe not even like some just called it poorly differentiated carcinoma, like not even thyroid. And so I guess the big thing might be to make sure not to overcall these as anaplastic and to consider other factors when evaluating this type of atypia.
That's great, thank you. And I would remind especially the trainees, always keep in the back of your mind metastasis in these, or something. There's a lot of weird things that they don't often, they can show up in the thyroid, Langerhans cell, what is it, settle, thymic tissue. All these things can show up in the thyroid. So if you see something weird, it could be something weird. And what I do is I show it to somebody more senior than myself. Plus, there's obviously molecular testing and other tools at our disposal.
And yeah, I totally agree. And also, I saw surgical pathology here sign out follicular carcinoma called high-grade follicular carcinoma. So in those cases, they may have few polymorphic tumor cells. So I didn't read WHO classification, what the criteria for high-grade follicular carcinoma. I think maybe there's a new category. Yeah.
It makes it tough for us.
I know, high grade. I was thinking, yeah, what a low grade looks like. But
so I see another. Sorry.
Yeah, sorry. My point is for those polymorphic cells, they can be, thyroid primary and can be metastatic. Even in thyroid primary, they can be so many subtypes. So it's kind of a difficult on FNA. We have very limited material, and we don't have so-called architecture background information, how much fibrosis and all those, infiltrating features. So it's hard. Thank you.
Thank you. I do see one more question in the chat here. It says, in case of cytologically suspected follicular neoplasm and availability of DIFQuick/GIMSA type stain, would an absence of flame cells and colloid raise a possibility of extrathyroidal origin and potential performing thyroglobulin TTF1? And I absolutely, I would say absolutely. It's just so thyroglobulin as a laboratory test, you need to have a laboratory that is validated to do that test, or a laboratory that is willing to do it without validating, which is tough to do. And then TTF1, you need a cell block or a laboratory that is validated to do immunocytochemistry rather than immunohistochemistry, and those labs are getting more and more uncommon. Again, the correlates of these would be chemistries for parathyroid hormone, or possibly GATA3 as a surrogate. But the molecular tests, the commercially available molecular tests will also pick up parathyroid. They may or may not pick up metastases. So, you know, you don't want to use that as I tell my trainees, you don't want to use that as a crutch to rely on the molecular testing, but it certainly can be helpful. Joanne is saying that no other questions have come in. You know, I'm really glad, Dr. Lam, Dr. Saoud, that you're welcome to join us. Is there anything else you guys want to add? Anything that I missed?
Yeah, we just wanted to say that thank you so much. I mean, this is really nice to see it discussed like this, and thank you, Dr. Heymann and Dr. Lee.
Yeah, thank you so much.
All right. Well,
Thank you,
thank you,
guys.
thank you, Dr. Lee.
Thank you.